Now that RP Singh, Rajendra Prasad is coming here with a special needle to manage the hypermature cataract to avoid intumescent, to flex Argentinian signs. Dr. RP.
I just had a small query to Saurabh. Saurabh, you said you will inject adrenaline, not the Mediratics, which is available now with the tropicamide and adrenaline.
Yes.
So why you said only adrenaline?
Yeah, I think we can use both. This video I made a little time back, so at that time it was not available.
No, would there be any difference in using both differently?
I'm not sure. I have not tried.
See,
Have you
actually, in floppy iris, you very rightly said you should inject only adrenaline, not the tropicamide,
tried? Okay.
because tropicamide will relax the sphincter, and then you'll have a more prolapse.
Okay.
But if you use only adrenaline, the sphincters will be tightened with the dilator muscles contracting, the pupil will be strengthened. So you get a little less. I practice that.
Okay.
I make a diluted noradrenaline
Yes.
or phenylephrine. Yeah.
Thank you, sir. Great
Thank
point. I didn't know that, so thank you.
Thank you. Okay. So I'm going to talk on intumescent white cataract, eminent to Argentinian plaque sign. We come across a variety of these intumescent cataract, different grades, different types. But what is common in all these cases is like they have very high intralenticular pressure. There is a tense and stretched out thin and fragile anterior capsule, hyperhydrated swollen cortex, cortical liquefaction, which is with the multiple fluid pockets, and there is a large voluminous nucleus. So all these factors make the surgical procedure a little difficult in these cases. So what happens when we puncture the capsule to raise the flap, because we have to start the capsular axis. So what we do, either we puncture with its 26 gauge needle, or we use the sharp tip rhexis forceps to puncture it. And when we puncture it, you can see like the fluid or the pressure which is there in the intralenticular space, it bursts out. It's a kind of volcanic eruption, because now it's not only the fluid which is coming out, it is the intralenticular pressure which is dissipating from that point where you have punctured the capsule. And even the forceps, because you tear the forceps with the help of you tear the capsule, and there also you get this kind of eruption of the fluid and the pressure. So what happens many times when you puncture this capsule with the 26 gauge needle, the pressure which is releasing here and the high intralenticular pressure, what happens, the puncture which you created on the anterior capsule start extending to the periphery, and it results into that Argentinian plaque sign. So to manage this, we have a variety of technique. Dr. Kamal has shown so many beautiful technique of T sign, and there are other techniques to deal with this. But I'm going to talk a little different technique. So these are some of the technique which you all know. You all have been practicing the mini rhexis, like one stage or two stage rhexis, and so many techniques are. I'll just show you one video. This is mini rhexis, what I'm trying to do, because before you start the capsular rhexis, just make a very small rhexis first, then evacuate the fluid from the intralenticular space, release the pressure, flatten the anterior capsule with a good viscoelastic, and then you can start the capsular access. So this is one of the very commonly practiced technique. And the another technique is one stage or two stage spiral capsular access, like you start from the center and slowly increase the size of the capsular axis. So what you can do is like, but in all these cases must stain the capsule so that your visibility is good. You know the progression of the capsular axis. This is how you can do this one stage capsular axis. Start from the center, keep it small, very small in the beginning, and then slowly enlarge it with the spiral capsular axis, like I'm just trying to take it slowly all around. And then you get the good size of capsular. Never make very large capsular access in these intumescent cataract. Keep it within 5 millimeter or 5.25 millimeter. So that would be enough for the emulsification of these little softer nuclei in these cases. So this is what we do, a one stage spiral capsular access. Then there is a technique, two stage. So I'm just omitting this video. It's almost similar. And another important technique which we all practice is the small needle aspiration technique. In a small needle aspiration technique, what we do is we use a 26 or 28 or 27 gauge needle and puncture the anterior capsule and then start aspirating. But many times what happens when you're puncturing the capsule with the 26 gauge needle, you could see a linear cut is formed on the anterior capsule, and many times with this technique also you get an extension of the capsular tear to the periphery. And this is what happens because like when you try to puncture or try to aspirate the fluid from the capsular bag, before you could do anything, like you could handle this, there's a spontaneous extension of the tear to the periphery, and it's out of control. You can't do anything because because you have punctured it with the needle. So what happens actually when you use the needle or capsular access forceps? So you can see the needle. What does the needle? Needle is like a knife. It has a sharp cut. When you puncture the capsule, it creates a cut on the anterior capsule. It's a linear cut which is created on the anterior capsule. And if you use a capsular access forceps, in capsular access forceps also we just puncture the center and then tear it. So this is how we tear. Now if there is a very high interlenticular pressure in this space, the linear cut would open up easily because the non-linear cut has two open edges. And this is what happens because the open edges will start opening because of the high interlenticular pressure. And this happens. This is the main reason why you get a Argentinian flag sign in these cases. So what we have done is, because we had a thinking like why to make a linear cut on the anterior capsule, why not to make a small hole in the anterior capsule? So that is called as a micro rhexis. Mini rhexis is a different thing. This is a micro rhexis. So we devised this is a device. This is called as a swing needle microcapsulotome. You can see the tip of this needle is round and pointed. It's unlike the hypodermic needles. So when you puncture the capsule, you get a hole formation on the anterior capsule. And you know that the hole has a much bigger resistance because it's a circular. So it has a much better resistance than the cut which is created on the anterior capsule. Now this hole will hold on the pressure because when the pressure is releasing from the interlenticular space, the fluid or the pressure, this hole will hold while the cut will open up easily. But this is a common physics in this situation. So what we do is, now these are the different types of the intumescent cataract because this technique actually may not work in some of the situation, but it works in most of the cases, most of the situation, almost 90% of the cases. So this is a needle. This is what you can see here is a simple sewing needle. The needle which we use for stitching at home, that needle can be used. The iron needle, steel needles are available. You can just bend the tip and then puncture it. So once you puncture, you have released the pressure. The capsular bag is now flattened. Now, as Dr. Kamal said, even a single drop of the fluid which comes out of the capsular bag releases the pressure. So it's not only the drop, actually there is a gas and the other pressure which is coming out along with the fluid. So even a small compression of the bag would give you a well relaxed and flattened anterior capsule. So these are some of the different types of intumescent cataract. Now this is what you can see here is the intumescent soft immature white cataract. There is a hyperhydrated fluffy cortex, and you would get a milky white fluid coming out of these. Always stain, this is very important because in these cases, and then flatten the anterior capsule. Don't inject too much of the viscoelastic in these cases because if you over pressurize the anterior chamber, then the capsule will go again in a tension. So inject very little amount and then puncture. Now this is the saving needle which is commercially available, different, not the home needle. You can get it the commercially made needle also, which releases the pressure. Now this is type 2 and different types. So I'll just short up time, I'll omit this video. I'll just show you this. This is hypermature white cataract where you have a very hard nucleus also along with. Just puncture and you get a fluid which is coming out, release the pressure, inject good amount of the viscoelastic, and then you can start the capsular axis. And this now, because since the capsular bag is now decompressed and the capsule is flattened and relaxed, so you can make a large capsular axis also in these cases, because now in this situation where you have a very hard and brown cataract inside, you can make a little larger capsular axis. So because you have to tackle this hard cataract within the bag. So as you can see, because rest of the factors, the vector factors have Dr. Kamal Kapoor has just explained how to use the centrifugal and centripetal forces, because you have to balance these forces in making any of these capsular axis in this situation. This is type 4, the last one. And as you can see, this is a Morganian category. You have a lot of fluid. Here also you can release the pressure with this needle and then evacuate this fluid, and then you can start the capsular axis and complete the axis and start emulsification. So what you do, like if you have this kind of extension, then the very simple technique, you have to give just 2 nicks along this the radial cut and make a small semicircular kind of axis, because you have to distribute the pressure before emulsification. Because if you start emulsification here in this situation, would further extend the capsular tear to the posterior capsule. The only important things like the tear which is created should not extend to the posterior capsule. So this is what you can do, and thank you very much.
Thank you. I think we always see new innovative things coming from RP boss here. And the best thing is he's got a thinking mind and he keeps applying them in the instrumentation and the equipment and making lives easy